Tonight's webinar on scleral lens fitting made as easy as 1, 2, 3, introducing the new Atlas scleral lens design. My name is Craig Norman, and I get the wonderful opportunity this evening to be the moderator for what I think you will find to be an extremely interesting and educational webinar this evening. The webinar is brought to us by our sponsors, Excel Contacts, which is a Wallman company, and the Bosch & Lomb Boston GP and Custom Soft Lens group. Before we get started, I would like to go ahead and just make a couple of housekeeping mentions if I could. For those of you that aren't familiar with the webinar format, there is the opportunity to look at the upper right-hand portion of your screen, and you'll see a little dashboard that is similar to what you see on the slide in front of you. And that dashboard allows you, most importantly, to be able to ask questions. Tonight, we want this to be as interactive as possible. We have quite a few people involved, so it's very difficult to make everybody live for the question part. But we want you to type in your questions, and we will have today's speaker, or we will have some folks from Excel Contacts be able to answer those questions for you. So before we get started, just to make sure that systems are go for everybody, could you go ahead and just type in your state into the questions box area in your screen? That will tell us that you have actually been able to access this questions mode, and that everything is working for tonight's webinar. The other thing I'd just like to mention before we sign off on this particular slide is that if you do have any technical difficulties, we do have people that are able to help you, and if you would call 574-277-0718. If you have any technical difficulties, then we will be able to help you with that. Now, before we go ahead and introduce tonight's speaker, I would like to make mention of the Excel team that is extremely excited about bringing this new scleral lens product to the marketplace. And I'd like to do that by first starting by introducing Linda Glover. Many of you may know Linda. She's the National Sales Director. And Linda, do you have a few words to say for our audience this evening? And I guess that Linda has very few words to say this evening. We aren't able to make contact with her. Linda and Tony Caparelli were in Atlanta, and we had hoped that they would be able to say a couple of words. But I will ask Cassandra Gordon. Cassandra, are you available and able to say anything to our audience?
Yes, Craig. I would like to thank everybody for attending tonight, and we hope that you learn a lot and take a lot away from this webinar. Thank you.
Okay, very good. Cassandra is the National Key Account Manager, and many of you may have actually had the opportunity to work with her. But now, to just get the webinar moving for tonight, it really is my great pleasure to introduce tonight's speaker. It's Roxanne Chung-Cohn. Roxanne is presently in the Orlando area in private practice. I've had the opportunity to know Roxanne since she graduated from NECO and went on to have a cornea contact lens residency at Pacific University. Roxanne, in my mind, is definitely one of the up-and-coming speakers in the scleral lens community, and I think you'll find her very, very enjoyable as a speaker. Now, Roxanne, before you jump in to our audience, I'd just like to remind them, please remember to type in any questions at all that you will have, and we will be sure to answer them. We'll have 3 or 4 breaks during the presentation to be able to address them. Roxanne, welcome so much for coming tonight, and we look forward to hearing from you.
Great. Thank you very much, Craig. So in this first slide here, we see some examples of irregular corneas that can come into our practice. So how do we fit these patients, with soft torics, soft keratoconus lenses, hybrids, gas perms? But what we're going to focus on tonight is the scleral lens. So here's a picture of the scleral lens of the past where we used to fit the sclera. Here is today's Atlantis lens, this scleral lens, and this can go up to about a 23 millimeter. This one's about a 15 millimeter diameter, and here's your everyday gas permeable lens. Kind of give you a reference point here. So why would we fit scleral lenses? So first of all, it does help make our vision better. makes the patient's vision better. So if they have any type of irregular stigmatism like keratoconus, pellucid marginal degeneration, post-corneal trauma, post-keratoplasty, or post-refractive surgery, a poor outcome with that, or post-herpetic disorders, that will definitely improve their vision. And then also, if it's difficult to fit this type of cornea, for example, this patient here who has keratoconus, they have a very flat superior and a very steep inferior. And it's hard to get a lens stabilized on this cornea. So if you're having a lot of gas permeable centration problems or rocking problems, this will be a great idea to switch them into a scleral lens. Another reason why you would use scleral lenses is to protect the cornea. So if you have any type of ocular surface disease like the chemical burns, ocular pemphigoid, Stevens-Johnson syndrome, symblepharon formation, graft versus host disease, persistent epithelial defects, exposure keratitis, neurotrophic keratopathy, and the one I really like to use it for is severe dry eye. So if your patient's on Restasis, you have the plugs, you're on drops, using gel, doing their fish oils, omega-3s, they're on steroids, and there's just no way to get that better, a scleral lens is a great solution to help solve this dry eye. But let's not forget the normal eyes too. So patients who've worn gas perms in the past where they're starting to have a lot of problems like a lot of 3 and 9 staining or VLK developing, patients with a lot of astigmatism, they're also great candidates for scleral lenses if they have a windy or dusty environment, and for athletes. So a great example I can think of is a baseball player where the ball is coming really quickly. They don't have to worry about rotation of their toric contact lens. And I actually had a patient here in Orlando where they work at the Cirque du Soleil show, and she had a lot of astigmatism. So a scleral lens was perfect for her because she's, being thrown around in the dark, up in the air, and, doing cartwheels and things like that. So it's really important for her to have exact, precise timing and to have the best vision possible. So she was also a great candidate for the scleral lens. It's also great for the presbyopic population and maybe in the future orthokeratology where, again, we can get that better centration. So this is what the Atlantis semi-scleral fitting set looks like. There are 24 lenses in the set. There's a fitting guide available in it, also an INR guide. There's also single-use saline right here. There are a couple small DMVs and large DMVs, some lap towels, and some lens tweezers. So these lenses are made with the great Boston materials. The Boston XO and the Boston XO2 is recommended. And of course, they have a very high decay of 100 and 141. So we're going to go over how to fit the scleral lens. And it's a very simple fit because it's only 3 zones. And that's why we call it the 1, 2, 3 fit. So here's the shape of the cornea. There's a little bit of a curve here, and the sclera also has a very slight curve but more of a straight line. And the Atlantis lens kind of follows that curve. So we have your central zone here, and then we have the limbal vault zone, and then the scleral zone here. So there are our 3 zones. So here is the Atlantis semi-scleral lens with the central zone again, the limbal vault zone, and the scleral zone. So step 1, we're going to talk about zone number 1. Zone 1 is the central zone. Now, what Atlantis did was they came up with these lens markings. So you can see exactly where their zones are, and here it is, central zone number 1. And this is the first zone we're going to use to fit the lens. You can see it here with fluorescein, central zone 1, and there's actually 2 markings on the lenses. Here it is with blue light and a Ratten filter, and you can actually see that pretty easily too. Now the central zone is the first zone you want to adjust in the 15 millimeter diameter because the fitting set comes in 15 millimeters and 16.5 millimeters. But usually 15 millimeters is a good starting point. Now what you want to do is look at the fluorescein pattern with blue light using a Ratten filter, and you want to scan the lens from left to right with an optic section, making sure that there's tear film all the way across, and then having the patient look down and up and making sure that there's tear film underneath and below the lens also. And the fitting set can fit pretty much most of the eyes that I've seen. So what we're going to look for the central zone is about 300 to 400 microns thick. So here you can see the optic section of the lens. Here's the tear film, and here's the cornea. Now the cornea is about 550 microns thick. So most practitioners say, well, you want about a third of the cornea for the tear film right here. Now I find that a little bit not consistent because the lens itself is about 200 to 300 microns thick depending on the prescription. So if the patient has keratoconus and it's central and there's a lot of thinning here, that's not going to be quite exact. But the lens, it's about 250 to 300 microns. So I like to have that tear film to be about the same width as the lens. And that's what you're looking for. Now if you have an OCT, it's really nice because you can actually go ahead and measure exactly how much tear film you have. So that's the first zone. Now the second zone is step 2. That's the limbal vault zone. So here is the lens, and this is the limbal vault zone 2. And here you can see it on the eye. So this is in white light, not even with fluorescein. It's still pretty easy to see. Here it is with the blue light. Now the limbal vault zone starts from exactly where the limbus is all the way out here where you see this fluorescein. So this is your entire limbal vault zone. Now what you want to do is you always want to make sure you have tear film right in this area 360 degrees as much as you can. And here it is on OCT. This is the limbus here, and here is the tear film. Now the limbal vault zone does exactly what it says. It vaults over the limbus. And the radii that are available are the standard, then 1 flat, 2 flat, 1 steep, or 2 steep. Now this does not affect the central vault zone, it only affects the limbal depth. So if there's not enough, you can just raise this up or down, the limbal vault zone, by how much you need to. 25 microns, 50 microns, whatever you need to do. Now here's a picture where you don't have enough limbal clearance. This is a picture from Pat Caroline actually, and here we can see there's a lot of darkening here. And here you can see on the OCT where it's actually hitting right here on the conjunctiva and the cornea. And the way to adjust that is you want to increase or steepen the LZ2 by 2 there. This is the staining pattern you get when you have an inadequate limbal clearance. So you're going to see a lot of staining here. So we don't want to have this type of pattern at all when we take the lens off. Now here's the appropriate limbal clearance. So again, we're looking for all that tear film to be flowing out of here. So there's good tear exchange. And here you can see there's just enough here where it just is above the conjunctiva and the lens. Now, when you look at the picture here, you're saying, oh, I think it's touching here. So you want to look at it overall diffusely on those areas. But just remember that this is the static eye in primary position gaze. You want to have the patient look over in different positions of gaze. So this spot right here, when the patient looks to the right, it's actually nice and clear here. You can see it fills in really nicely. So that's not actually touch here. Superiorly, it's the same thing. It looks like it's darker here, but when they look down, this is the type of pattern you get. And here looks also a little bit thinned out, but again, you can see there's nice fluorescein here and also at the bottom. So this is a great fitting lens. Third step, zone 3. It's a scleral zone, and that's right here, scleral zone 3. And that's the area from where the limbus ends out to where the diameter of the lens ends. And you can see where it lands right here, right on the conjunctiva. That's scleral zone number 3. So you can adjust the scleral zone, and there are 4 different radii available. There's standard, 1 flat, 2 flat, and 1 steep. And that changes the sagittal depth by 50 microns. So here is the diagnostic parameters of the fitting set. So they give you the standard here, and then they give you the steep and the flat zones. So you can see there's a 50 micron difference, and you can put it on depending on how much you want to go by. So when you look at the fitting set, here is the standard. These are the 50 millimeter diameter lenses, and these are the standard curves. And these are the steep, and here are the flat lenses, and these are the 16.5 diameters. Now this is the type of scleral landing that you want. And the way you can tell is if you have an OCT, you can use this, or you can look at the blood vessels. And you can see the blood vessels here flowing really nicely. Nothing's being cut off here. Now if you have conjunctival impingement, this is where the lens focally pinches on the conjunctival tissue. So you want enough peripheral clearance, and if it's not enough, you want to make sure the peripheral clearance is inadequate when the entire lens rests below the conjunctival surface. So in this case, there's too much impingement. What you want to do is go ahead and flatten the scleral zone, but increase the sagittal depth to make up for you want to keep the same fitting relationship. If you don't fix this, the patient will get conjunctival hypertrophy. Here it is where you get more of a broader, instead of just focally pinching, it's all conjunctival blanching here. And this is the type of staining you get here. And when you take this lens off the patient, they actually get rebound hyperemia. So again, this is not a very good fitting lens. So even after, when you first put the lens on, everything always looks beautiful. But you want to always check them about 2 to 4 hours after and make sure all the blood vessels are actually flowing nicely through between the lens and where the conjunctiva is being exposed after the lens.
Okay, that is really great, that initial introduction into how the lens is working. We have some questions, and I want to once again invite everybody else to write their questions in. It's always interesting with these webinars where people attend from. Not only do we have people tonight here from all over the U.S., but we also have attendee from Brazil and another one from Sri Lanka. So welcome very much for coming. So here's the first couple of questions that we have, Roxanne. The first one is related to the lens markings. And there's two questions here. The first one is, how helpful do you think those lens markings are for you in the trial lens fitting process?
Well, because I know the lens so well, I don't need them anymore, but I think when you're starting to fit them, you don't really know where they are if you haven't done the webinar. So I think they're helpful to say, oh, so this is where my central zone is, this is where my limbal zone is. So I think for a lot of people who are starting this, it's a great marker for them to help them with their fitting. And they can in turn call the consultant and say, in that area where that zone is, it looks like it's kind of dark, touching, and then they can get help from the consultant.
Okay, great. Because the second question actually is kind of related to that. In the example that you had shown for the limbal zone 2, that the markings were lining up so that the marking itself was just inside the limbus. Is that typically what you're looking for?
Yes.
At the end of that mark is where the beginning of the limbal zone starts, correct?
That is correct, yes.
Okay, excellent. And then when you make changes to the limbal zone, is 25 microns of change enough?
That's a question we don't really know, but I usually go a little bit more than 50 microns, but it depends on how it's actually sitting on the eye. So if there's actually a lot of clearance, maybe you just need a little bit more. So it all depends on how that lens is resting.
Okay, so if you had a rule of thumb, would you make these changes in just one increment or step, or would you think more in terms of making them in 2 steps?
You can do
initially. Or does it depend?
It all depends, but I think, if there's a lot of touch, you should do a bigger change, and if there's just a little bit, I will, just do a little change.
Okay, great. So we have 2 questions before we move on, and both are related to the patient selection process. The first one is, are there any type of cases that you find that scleral lenses in general don't work well for?
Actually, yes. Probably a patient who has a corneal transplant with a low endothelial cell count. I don't have a speculum microscope, but this is where you can talk to your corneal surgeons about it. They probably would not do too well in them, but everyone pretty much does really well with them because they're very comfortable.
Okay, so that's a very specific post-graft surgery kind of patient.
Correct.
Okay, and then the second one that follows up on that is, what are the most challenging cases have you found? And have you done RKs by any chance?
Yeah, I have done RKs, and you know, everyone's different, and some patients they complain more than others, but I mean overall fitting the lenses, I think they're actually pretty simple, but you just have to go based on, you know, the staining patterns and fix that, go by what the patient tells you, and we're going to go into more things that we'll talk about, you know, troubleshooting.
Okay, great. And then the last one before we move on is just related to the clearances that you talked about. So as a general rule, that the clearance that you want in the central zone is 200 to 300 microns, correct?
It's
and
it's actually 300 to 400 microns.
Okay, perfect. Yeah. And then in the limbal zone, approximately 100 microns or so.
Correct.
Okay. Okay, good. And I know you're going to get the chance to be able to address that even further. So, hey, everybody, keep those questions coming. That's great. And Roxanne, it's back to you to go to the next section.
Okay, so just to review the fitting tips here, the lens should be centered, and it should clear the entire cornea from limbus to limbus. So just right here. And then the second one, there should be no bearing on any part of the limbus. So that's where Craig talked about the 100 microns. And you want to make sure the weight of the lens lands on the sclera itself. That's where the most of the fitting is. So the Atlantis company, XL, they've recommended that you start with the C lens in the 15 millimeter diameter. So all you do is you pick that lens if you don't have any topographer or OCT or anything, and you put it on a patient, and then you decide, you know, if it's too steep, not steep enough, or if it's just right. And then you can go up and down that fitting set. You can also look at their corneal profile. So what you can do is either sit them, you know, behind a slit lamp and look at the corneal profile under the microscope, or you can just have them look at it with the naked eye, doing, you know, pulling that lid up and just seeing what that looks like. You can actually hold a lens off to the side. So, you know, you can determine if this is going to be a shallow lens, if it's going to be medium, or if it's going to be pretty steep. And again, it's just choosing the right, let me just go back to the fitting set here. So then you can, you know, go if you want to go to a really steep one or a really flat one. These are all the sagittal depth readings here. Okay, so again, you just put that on, and again, you look at it. Too steep, too flat, or just right. And you can go up and down 100 microns or 200 depending on how much you need to. And the great thing is you can call into the consultant and say, you know, I want to drop that down by 200 microns, or you can just grab your fitting set and put something on. So another way to fit it, if you wanted to be more exact, is fitting it with the OCT. We're going to fit it by sagittal height. So what you do is you take that 15 millimeter cord on your OCT and you measure up to the apex of the cornea. In this case, it's 3.82, and then you add your 300 or 400 microns, and this is the sagittal depth you pick. So again, you choose whatever's closest in your fitting set to that number, and you put it on, and you just adjust it accordingly. So most of us don't have OCTs, so what we're going to do is explain to you how to fit it by topography. So we did a study at Pacific University where we compared the normal eyes versus keratoconus that we presented at the Global Symposium this year. So we took 55 keratoconic eyes, and we measured the cord at 15 millimeters and also at 10 millimeters. And we found the sagittal depth to be about 2,000 microns. Then we compared it with Pacific University's normal data, and here, right at the 15 and the 10 millimeter cord, the difference again was about 2,000 microns. We also took the angles, so nasal and temporal angles of the keratoconic eye. And here are the normal findings. So you can see it's 38.4, 39.5, 38.2, 37.2. These are very close. So here you can tell that the eye itself is very symmetrical. So the only difference was from the 10 millimeter cord and up, the difference was 217 microns, and that depended on how severe the keratoconus was. So we're going to use set magic number of 2,000. So on most topographers, and I have a Medmont here, you can take the 10 millimeter chord where it gives you the sagittal depth, and here is your average depth here, 1727. So we take 2000 from our study, and then we add the 1727, and we add the 300 or the 400 microns, and this is a total sagittal depth that we're going to start. So this is our starting lens right here, 4127.
Okay, great. That's some real interesting information, I think, as we look at the ways to go ahead and choose the initial lens with the Atlantis. So a couple of questions that we have regarding the OCT in particular, and that is, do you need to have an anterior segment OCT like Visanti or so on, or can it be a OCT that's primarily designed for the posterior chamber?
You need an anterior segment OCT. I actually have a Heidelberg OCT, but I'm not able to get all the way out at 15 millimeters. But I know that they're trying to get everything FDA approved right now, but it's not. So the Visanti is the only one that I know of that will measure all the way down to the 15 millimeter cord.
Yeah, like you can actually, my experience at least has been, Roxanne, you can get some imaging, you know, from something like Heidelberg, or even the Zeiss unit that doesn't have the anterior segment attachment, but it's not with the clarity that you get with Visanti, of course.
Correct.
And then in those measurements that you showed, where there were both angles along the angle at the nasal and the temporal area, I don't think that you mentioned anything about the vertical measurements. And do those mean anything to you, or is it just purely along that 180-degree meridian?
We were not able to get we didn't measure the different angles. We just measured at the 180-degree angle, like you said, nasal and temporal. Correct.
Okay. Okay, good. And then just to reiterate before we go along, with a design like Atlantis, while it's great to have both the topographical measurement and if you have OCT, you don't really need it to be able to choose the first lens. Is that correct?
That's correct. So you can either use the corneal profile like we talked about, or just start with that C lens and just look at the lens on the eye and then go ahead and adjust the fit.
Okay, that is terrific. So I think that's the questions that we have at the moment. To all the attendees, please keep them coming. And Roxanne, why don't we move on to the next section?
Okay, so when you fit the patient, you know, that's great, but what if they can't get it in? So we're going to go over a little bit of application and removal techniques here. So first of all, you have to choose the right patient. You got to check their aperture of the lids, how deep their eye sockets are, how tight they are, if they have any type of blepharospasm tendencies. Check their dexterity, and if they have large fingers, it may be more difficult for them to put them on. But here are some pictures of some applicators and removers. Here's a large DMV where we usually cut the end off so there's no suction. So they can go ahead and use that for application of the lens. Here's a small DMV that's used to remove the lens. And here's an O-ring. This O-ring you can get either from an orthodontist, or you can buy it at Lowe's or Home Depot. I've actually never looked for one, but I've heard some practitioners actually use this here. Now the picture we've seen just before this was this one, and this is from the Boston Foundation for Sight. This is the actual holder for the plunger here. Now the nice thing about this plunger, there's actually a hole in it, and there's a light that you can plug in. So when the patient looks into the lens, they can see the light, so we can actually tell them if the lens is centered or not, and it's a lot easier for them to put on. There's also a product called the Easy Scleral Lens Applicator, and basically what it is, it's a ring you use, and this ring expands depending on how thick the fingers are or how thin they are. So this ring expands, and you basically put your scleral lens right over the top here, and you use that one finger, and you can apply the lens with that ring. Now it's very important you tell the patient to use preservative-free saline solution to fill the lenses. So one option is to use Unisol, but this is a pretty big bottle, and you may get contamination. And the other is using sodium chloride inhalation solution. And that comes in about 3 to 5 mLs, and there's about 60 to 100 in a box. Now they're looking at this box and saying it's inhalation. So you got to tell the patient this is used in asthmatics, but you're just using it off-label to fill the lens because it's basically preservative-free saline solution and it's its unit dose. So everything you want to be very hygienic here. So you can either write them a prescription for it, or what I do is I actually sell it in my office because it's just more convenient when the lens is being dispensed. So I just include it in my package and they can purchase as needed. So you can do it either ways. Another option is to use a pure lens solution, and it's kind of pretty much the same as a Unisol here, but the difference with the pure lens solution is that you can put the lenses into this basket here, kind of like a peroxide system, but it does it in 15 minutes. So you can use this pure lens solution to either clean the lens and also to fill the lens at the same time. So we're going to discuss how to put this on. So the Atlantis lens, they provided some lap towels that you can use to put on to the patient's lap here. And what you want to do is go ahead and fill the lens up here, apply your fluorescein, and then you can either use your DMV with the hole in it to put it into the eyes, or you can tripod it. And you must have the patient look down, and you have to make sure their eyes are parallel to the floor. So here it is, when you're putting it on to the patient, have the patient look downward and they can tuck their chin in towards their chest. And then you hold the upper and lower lid where the eyelashes meet and hold the plunger at a 45-degree angle here, aimed at the bottom of the lens, and just put it in very quickly and gently. Now if you put this in and you get this type of bubble, you know that this is an application bubble here, and these tend to be off on the side. If you have a central bubble, that means the lens is usually too steep. But this is the same exact lens applied after, and here you can see it's perfect. Now why do we get bubbles? So one is if the lens is placed off center when you put the lens in, so the patient's eyes has to be parallel to the floor, or if the lens does not have enough fluid in the bowl. So after you put that fluorescein in, make sure you fold this until you see a bowl like this. You want it to actually be nice dome-shaped tear film here, a nice artificial tears that you can use in here to put it into the eyes. Now if for some reason the patient keeps filling this solution, you can use a thicker solution. You can use Solubis to fill this up with. Now another reason for bubble formation is after a few hours of lens wear, they complain of bubbles. This is because the lens is flexing too much. So you can go ahead and increase the thickness of that lens. Now when you want to take the lens off, what you do is you wet the small DMV with saline or preservative-free rewetting drops. And you take the DMV and you put it on the lower third of the lens, and you just gently remove it from the eyes. But sometimes they don't always have a DMV with them, so we always teach our patients how to take the lens off without anything, just using their fingers. So it's kind of like taking out a gas perm, but this is obviously a much larger lens. So you basically hold their eyes open, have them look down so that your finger is holding the edge of the top of the lens right here. And then you have them look straight ahead, and you grab the lower edge of the lenses right here on the bottom. And you either push on the top or the bottom, and the lens will gently come out. As soon as you break that suction just a little bit, the lens, you can see the bubbles filling in, and it pops right out very, very easily. So when the patient comes back, what do you do? So when I first dispense the lenses, you could have the patient come back 4 hours later if they're working close by, or if they cannot, I dispense the lenses and I see them up the follow-up the next day. But when you see them for follow-up, you don't see them as soon as they wake up. You tell them, I want you to wear this lens for at least 4 hours before you get into my office. And as soon as the patient arrives, we put fluorescein into their eyes. Before we even do the case history, my techs do that. And by the time I get to see the patient and do the case history and everything, it takes about 10 to 15 minutes for the fluorescein to get back there, and I can determine, if there's tear exchange or not. And if there's no fluorescein behind the lens, we know the lens is too steep, so you want to adjust it by flattening that scleral zone. And then typically after I see them back the same day or the next day, then I see them back in a week, and then a month, and then 6 months after that. Now, what if they said their vision's blurry? So here are some of the causes of blurred vision. If they have too much clearance centrally, you want to flatten that central zone. Or maybe they have poor wetting or deposits. So we see some deposits here, and here's an example of poor wetting. So they can clean the lenses. Or maybe they have poor tear film, so you have to treat their meibomian gland dysfunction. Now, you always do a spherocyl overrefraction to make sure the powers are right, of course. But if you're getting that spherocyl refraction, it means that the lens is flexing, so you want to increase that lens thickness. So if you discover it's not the flexure, maybe you have some type of internal astigmatism that's not corrected forward, so you can order a toric. Or you can just prescribe glasses, whichever is better for the patient. You will also get blurred vision by bubbles. So I talked about that earlier, where they're wearing the lenses and then a few hours later they notice bubbles start going into their eyes because of lens flexure. That will also cause blurred vision, of course. Now sometimes they say, well, I could see, but everything seems really foggy, and that's caused by chamber debris. So there was a study done by Weiser, and I'm not sure if I'm saying that right, but basically their study found that 49% of scleral lens patients have to remove their lenses 1 or more times a day. And that's what I recommend to the patient. Just take your lenses off, put in fresh new solution. Now other doctors I've known, they've actually prescribed antihistamine drops to help with that, to help reduce the debris. Or if you want, you can also reduce the sagittal depth a little bit, because less tear film means there's less debris that they're looking through. So here are some of the cleaners. So you can use the Boston Daily Cleaner, which is an abrasive cleaner from Bausch & Lomb, and this removes a protein. Or you can use the Medicon or low bob solutions, and these are non-abrasive cleaners, and they remove the oil and organic buildup. You can also use an extra strength cleaner. So Miraflow used to be a great cleaner, but they don't make it anymore. So I tell my patients, go to Walgreens, and you can get this extra strength daily cleaner, which is very comparable to the Miraflow. Now, I know there are some people listening from other countries right now. If this is hard to get from Walgreens, you can actually go online and you can find these other two products. I found these on Amazon, and you can just order these online. Now, what I highly recommend is the peroxide-based system, because again, I want everything that's preservative-free. So you can use Eosep, ClearCare, Softlawn. Now, if the lenses have a lot of buildup, and I see the patient back every 6 months, I can go ahead and just clean them with the Boston Lab Cleaner, or you can use Progent. Now, Progent works in that you use these two vials, you open these up, and after you put the lenses in there, you just mix these two vials into this container. And you have to take it out in 30 minutes because the lenses will discolor. And these are very powerful cleaners here. Now, all of the Atlantis lenses come plasma treated. And this is a great way to remove any oils and waxes from the lens once they're made. Now, it also produces a hydrophilic lens surface that is resistant to protein. So it'll give the patient better comfort, and they can wear it for a longer period of time. Now, when you look at the lens fit centrally, if there's a large bubble or excessive apical clearance, if there's a lot of clearance, more than 100 microns, you want to flatten the base curve by a whole diopter. This is where you get the biggest change, or you can reduce the diameter. Or if you have less than 100 microns, you can flatten the scleral zone by a little bit, because it's not as much, or flatten the base curve by only a half, or reduce the diameter. Now, this is a patient. Every time they come back, you tell them what to do, but we know, most of our patients, a lot of them are not compliant. So they go buy some other inexpensive solution to fill their lenses with. So this is a patient who came in, and they had a lot of staining because they were using a multi-purpose solution. So this is typically what you would see. So again, just to reiterate to them, you got to use something preservative-free to wet your lenses or to fill your lenses with. Now, if there's lens adhesion, it can be caused for a lot of reasons. If there's not enough corneal clearance, if there's not enough limbal clearance, if there's lens flexure. So again, you just go ahead and increase the thickness of that lens. And I know we said that dry patients are great for the scleral lenses, but they're the ones you have to really recommend a lot of preservative-free wetting drops. And they may even need to clean your lenses with the extra strength cleaner once a day.
Okay, thank you very much, Roxanne. We have a number of questions, and once again, please everybody keep coming them in. They're all over the place, so I'm going to start first with lens care. And there's a couple of questions here. One is related to the extra strength, the so-called mirror flow derivative. Does that cut down on the lifespan of the plastic at all because it is an alcohol-based solution?
We might want to ask Excel about that, but I actually have my patients use it, and I don't see a problem with the breakdown of any type of plasma treatment. So I don't know what your experience is, Craig, with that, but my patients do quite well with it.
Right. Well, I think, of course, the plasma treatment only lasts for a period of time on these lenses, somewhere between 30 and 90 days, which is what it's designed for. But my experience has been when you have an alcohol-based solution like that over a time span, 12, 14, 16 months, it might affect the surfaces a bit. On the other hand, it's a phenomenal solution to be able to keep the lenses clean, and I think it's a fair trade-off to be able to do that.
Correct.
Also, go ahead.
Well, you can also send the lens back in to get replasma treated too, if you notice it's not wetting as well. So if you notice that problem, just send it back in and get it all plasma again.
Okay, good. Then the other one is related to lens care also, and you talk about the use of hydrogen peroxide. Is there any problems with the size of these lenses and the basket size in, for instance, in clear care?
Most of my lenses I fit are 18.5 and less. So with those lenses, most of them fit into it, and if they don't, you can actually leave the lens basket open a little bit. So you can give them 2 cases, and it'll work just as well.
Okay, great. And I know that there are also larger cases that are available. They're special order, but they are available. I did want to make mention that device that you talked about where the patient can actually lean over and actually place their eye onto the lens in the stand is available from a company called Dalsey Adaptives. That's DALSEY ADAPTIVES.com, and they are the ones that supply them for the Boston Foundation for Sight. Another question here is related to the lenses, and that is, when do you consider the 16.5 millimeter lens versus the smaller diameter?
When you don't have enough limbal clearance, and if you notice their HVID is a lot larger than normal.
Okay, so you're still thinking in most cases the smaller diameter is the first choice, but under those scenarios is when you would think about a larger diameter.
Correct.
Okay, good. And then another question is, what exactly is plasma treatment? Shouldn't it last at least a year? I'll just answer that quickly. It's a treatment that is designed for lenses to give them a super cleaning. That super cleaning in effect makes them wet a little bit better, but it is not designed to last for a long period of time. The only material that is like that is the Menicon material, which must be plasma treated to allow its inherently hydrophobic surfaces to remain wet on the eye. So let's move on to some of the case histories then. And again, keep on the questions, keep them coming to us. But for now, let's talk about the actual understanding of how the lens works.
Okay. I'm just going to go into quickly, how to implement scleral lenses into your practice. So one is you want to choose a design. If you're now starting off, choose something very simple like the Atlantis design. It's just 3 different zones that you need to adjust basically. It helps to have a fitting set because you can see where exactly, if it's too steep or too flat on the eye. And that also helps with your returns because some companies only allow 2 to 3 exchanges, so you got to figure out what my return policies are, and having that fitting set really cuts down on the returns. Also attend workshops because there's nothing better than to have hands-on experience. You can also go to the Scleral Lens Education Society, and they actually publish it's called Eyesight Newsletter every month, and that's their website here, thesclerallens.org. And you can also market to your corneal specialists, put it on your website, other optometrists who don't want to deal with these types of corneas. You can contact the irregular cornea groups like the Keratoconus Foundation and the Stevens-Johnson's Foundation. So these are the coding, these are the basic codings of what you want to use for scleral fitting. So 92313 is used for scleral lens fitting, but you got to specify if you're doing the right eye, left eye, or both eyes. And for keratoconus, it's 92072. That's very specific to the scleral lens fitting for keratoconus only. And the scleral lens materials is V2531. Now, what I think is best to do is you call your insurance company and figure out, what's the best way to get it medically approved. But every company I've noticed has their own specific little codes they want. Like, for example, VSP, I did one today, and they said you got to fill out box 19. You have to put the name of the lens and the type of lens that you're fitting and the lab where you're getting it from. So even though you use the right codes, you have to figure out what does, the insurance company want so I can get this lens approved for my patient. So let's go into a couple of cases here. So here's David. He's a 27-year-old public defender. He had a history of poor success with gas perms, and he's currently wearing a synergized clear cone. He's healthy, and he was diagnosed with keratoconus 5 years ago. Here's his manifest refraction. So his right eye was 20/40. The left eye had a little bit more astigmatism, but I just couldn't get him to see any better. He was 2200. Here are his K readings. And here is the apex of his cone that I got from topography, 51.6 and 66.5, which kind of matches his vision here. Here's his topography in his right eye, so you can see his cone. Here's his left eye. So this topography, you can see there's a lot of distorted mires here. Now, those mires were distorted because when he came in with his clear cone lenses, there was a lot of staining. So going back here, this is why we can get a very good map here. So it looks really flat there because of the staining, and then there's his cone right here. When we looked at his eyes, you can see there's a lot of neovascularization. And again, this is why I'm not a big fitter of the synergized lens. I know they came up with newer lenses, but right now they're a clear cone lens. It has a very low decay, and I wanted to help him out with this neovascularization that was happening here in both eyes. So just like we did in our study, what I did is I took the 4 best readings in this case in his right eye, and this was his corneal sagittal depth here, 1937. And then I used my 2000 rule here, and I added my 300 to 400 microns, and this is the total sagittal depth of this eye. So when I looked through my fitting set, the diagnostic lens that was closest to it was 4349. So this was actually this lens right here. So I put that lens on, I did my over-refraction, and he was 20/20. So first fit, first try. Here's the left eye. Now this one I had a few less readings because it was hard to get a topography and it was very variable with all the staining, but overall his depth was 1845. I added in my 2000 microns here. Here's the 400 microns of clearance, and that's my total sagittal depth. So again, it ended up being the same lens, the D lens standard, and put it on, perfect 20/20 again. So this guy was a slam dunk, coming in, like a train wreck. But, all the staining cleared up and everything, and he was 20/20. Here's Deborah. She's a 29-year-old female. She was diagnosed with keratoconus in 2009. She wore soft contact lenses for 15 years, but she said her vision was not good. So her vision in her left eye was a lot blurry compared to her right eye. Her dad also had keratoconus. And here's her refraction. So again, she had a lot of astigmatism, but she was only 20/60, and the left eye wasn't too bad. Here you can see the K readings, 53.8 with an apical reading of 57. And again, the left eye didn't look too bad either here. But here's her map for her right eye. So again, we took our readings here. This was our weighted average for the height, 1834. So we did our 2000 plus the 1834 from topography, added our 400 microns, and this is our total sagittal depth here. So again, we go to your fitting set, and this again, it ended up being the same lens, 4349. So here's Deborah lenses. This is her right lens. So here's her lens, here's her tear film, and here's her cornea. So we also did an OCT on her, and we did notice that it was actually thinning out here a little bit. So centrally it looked good. It might have been a little bit thicker, but it got pretty thin down here. So we also did OCT nasally and temporally, and this is why she was starting to get a little bit thin. You can see the lens in her case was actually too small. Here's the limbus. You want to actually have this past the limbus, and here it is on, so this is nasal and this is temporal, and again you can see the same thing on this side. You can also see it on fluorescein pattern. When you did the optic section, you did see there was touch here. So what we did is we went actually larger. We went larger, but we adjusted the centrally to 4200, and this is the type of fit we got. And again, it still looks like it's touching, but again, have them look left and right, and this is what we saw. So she ended up being 20/20 in that right eye. This is her left eye. And again, same rule, 2000, when we added the 2217 from topography here, added our 400 microns, and the total sagittal depth was 4,617. So again, we go to a fitting set, and it ended up being this lens on this eye. And we're actually in the flat zone. So this is her left eye. Here's the lens, the tear film, and the cornea. Here's her OCT. And with this eye, we were actually able to fit it on the first try. And she went with the 15 flat scleral zone, and she was 20/20. Here's Beverly. She's a 55-year-old Caucasian female. She did not have keratoconus, but I still use a keratoconus rule. And she complained of blurry vision with her glasses and contact lenses, and everything I put on her soft toric, it just did not work, and she would not tolerate a gas perm. But she was 20/25, and she had pretty normal K readings here. Now this looks like it is keratoconus, but it's not when you look at her K readings. So she's really flat here and very steep here. Now this left eye looks worse than that. It's a lot flatter here and pretty steep here. So this is what I found on slit lamp. She had a lot of scarring here and a lot more in her left eye. And, you know, I think this could be a case of limbal stem cell deficiency, or maybe just a lot of severe dry eye. But regardless, I went ahead and I fitted her. So here is her sagittal depth of 1689. I added my 2000 microns on my 400 microns of clearance, and this is my total sagittal depth. Okay, and in this case, it actually ended up being this lens right here. So here's her OCT. Now, I wanted this lens here, but actually Excel sent me the standard lens. So there was this was a little bit thicker than I wanted, but that was okay. At least I saw the clearance, because I know this lens will eventually sink in a little bit. So I said, looks a little bit thinned out here, but you know, I went ahead, and here's her OCT, and here's the optic section, so essentially looks good. But I said, let's go ahead and just order up this lens, and again, she was 20/20. Here's her left eye, where we saw a lot of flattening here, and there's a lot of steepening on the side here. And again, just remember there's a lot of scarring going on here. So again, same rule. We did our topography at the 10mm cord, 2000 microns from our study. We added that 1837, added our 400 microns of clearance, and this is our total sagittal depth here. So we went to our fitting set again, and this is what we ended up with here, the 4349 lens. Here's the fluorescein pattern. And here's that dark spot again, and you just have the patient look over to the left. So this lens here looked a little bit steep, so what I did with this side, I just flattened it out a little bit here. So it went from here, so 4300, I went to 7.5. I don't know exactly how many microns, but he went from a 7.34 to 7.5, and this was the difference between this lens and this lens, just going flatter. And again, she was 20/20, and she's very happy with her vision and comfort. So as you can see, just applying that rule gives you a great starting point, and you just put it on and you evaluate it and decide, if you want to go too steep, look at the whole pattern and go from there.
Okay, great. So very, very good tips and great case histories related to how the Atlantis lens is working. We have questions, of course. The first one is, you had talked earlier about sometimes adhesion occurs because you have low clearance. Why wouldn't it occur instead when you had high amount of clearance?
I think when there's not enough clearance and the lens drops, because the lens drops by maybe 100 or 200 microns, it actually sticks to the eye. So that lens drops, there's actually seal-off, and then that's why there's lens adherence.
Because there's such close proximity then of the back surface of the lens to the eye.
To the eye, correct.
Okay. I mean, that sure makes sense. The next question is related to the example you used where you changed from a 15 millimeter lens to a 15.4. How did you determine that it should be 0.4 millimeters in additional size rather than some other increment?
Well, in her case, it was really small, so I usually go in 2 millimeter steps, and I decided to just go larger overall. And you don't want to go too big, but at the same time, 15.4 is not that big because you want most of that scleral lens resting on the sclera itself. That's where most of the fitting is, so it can really vault over the cornea. So you don't want any touch there. You just got to make sure you clear everything. So I went a little bit larger than normal.
Okay, good. I mean, that seems to make sense to me. The other question is related to when you make a change out in the periphery on the scleral curve, and you're moving the scleral curve either up or down. You had mentioned that you want to maintain the same sagittal height in the base curve area, though, if that relationship is what you wanted to see. Who makes that decision on how those changes are done? Do you do it, or do you call the laboratory for it?
Well, in my busy practice, I usually just call the lab, and I tell them, I want to change the scleral zone by this much, but can you keep the same central zone because that looks perfect to me? So they go ahead and they do the calculations themselves. And then I just get, whatever they work it out to be when they plug it into their computers.
So I totally agree with that, by the way, Roxanne. I think that, even the most expert people in the field in scleral lenses, when you come down to the exact mathematical calculation, you might as well be talking to the people like the Excel consultants who are talking about these lenses all day long and doing those calculations, and let them determine it. Next question is, do you ever use Atlantis for normal eyes? Now, I know, just commentary, I know that last patient was relatively normal, although she did have that weird superior appearance to her cornea. But do you just have any uses for Atlantis for normal eyes?
Yes, I do. Again, it's patients who have a lot of astigmatism. They can have 4 to 5 diopters of astigmatism, and you still can't get, a good vision with a soft toric. So again, the Atlantis, well, I used to fit a lot of synergized lenses, but they started adhering to the eye, so I found a great alternative was actually to use a scleral lens. And the patients love the comfort, and they actually last longer than a synergized lens too. So great vision, great comfort on a normal eye, yes.
Okay, that is great. Ursula, can you make the Atlanta folks live if possible? And we'd also like to get Cassandra on the line. And if so, the next question is really an Excel-related question, and that is, will Excel have fitting sets to borrow like what is done with the Titan?
Craig, this is Cassandra, and yes, we will have a limited number of fitting sets available for loan, so you'll just need to contact our office and see what the status of is, if there's any available at that time.
Okay, that is great. And then Roxanne, could you make any comments about consultants and interacting with consultants? I know for me, I mean, I'm an old guy veteran, but I use consultants all the time because I think that they actually know a little bit more on individual cases, what is going on, than just myself. Do you happen to use them quite a bit?
Oh yeah, sometimes, just for a second opinion, I call them up and say, do you think I should do this? And what do you think about this? And we actually exchange a lot of ideas, and we actually learn a lot from them too, because this is what they do all day long. So definitely, and there are some really great consultants at Excel.
Yeah, I would totally agree. That the consultants, of course, they're talking to people about, in this case, scleral lenses and the Atlantis design all day long, where we may be doing 1 or 2 new fits a week, whatever it might be, or even less. And so it really is nice to have that additional person looking over our shoulder. Cassandra, before we turn it over to Dr. Cohen for her closing comments, do you have anything you would like to say?
Yes, you will find Allison Pinn and myself, our contact information. If you have any additional questions, you can reach out to us, but we will be reaching out to each of the participants sometime tomorrow. So thank you for attending the webinar. We really appreciate your attention and your time, and hopefully you took a lot away from tonight's webinar.
Okay, great. That is terrific, Cassandra. And Roxanne, do you have any closing comments for our guest this evening?
Yeah, scleral lenses look scary at first, but they're actually, once you get into 3 or 4 fits, they're very easy to fit, and they're actually very rewarding in a lot of ways. I've had patients cry in my room because they're just so happy, and to change someone's life like that is so rewarding to me. So definitely learn to use a scleral lens and change many lives.
I would totally agree with the last statements that the utilization of designs such as Atlantis and others in this category really is life-changing for our patients. And on the other hand, they're very interesting and exciting and intellectually challenging for us as practitioners. I'd like to very much thank Excel Contacts along with Bosch & Lomb Boston Group for sponsoring this evening. Cassandra, thank you so much for your input, and especially for Dr. Cohen. Roxanne, thank you so much. It was a really interesting presentation, and I know for me I picked up a couple of tips, and I'm really hoping that others that have been attending tonight did the same. So thank you everybody for attending, and as was mentioned by Cassandra, that she or Allison or someone from Excel will be in touch with you. But with that being said, good night everybody, and thanks once again for everybody attending. Take care.
Great. Thank you.